Thank you so much, Dr. Abhay. Truly grateful to the first family in cataract surgery for repeatedly including me in your wonderful symposium. I deem it an honor. So my premise is to deal with unhappy postoperative patients. These are my financial disclosures, and some of the products I'll be discussing are manufactured by these two companies. I think the most important aspect is to preoperative counseling. Whenever a patient comes to me for a premium intraocular lens, whether it's multifocal or torics, the points we want to drive home is that we are not promising total spectacle independence, but relative independence from glasses. And dysphotopsia is the price they pay. You buy vision for all distances using the currency of contrast. Usually recommend bilateral surgery because once the new occipital cortex is getting similar impulses, it seems to adapt much better. And a secondary touch-up procedure may be needed, and adequate time has to be given for neural adaptation. So once you have spent this time explaining this to your patients preoperatively, most often it's easier to deal with them postoperatively, not that they don't come up with problems. And when they come up with problems, these are the 5 C's. The last C, crazy patient, is what I thought was most common, but now I realize that once you are perioperatively, intraoperatively, and postoperatively dealing with all the other 5 C's, your incidence of dissatisfaction does come down significantly. It was in our inability to understand the problems that the patient is presenting with that used to make us label many of us patients as difficult patients, crazy patients who are complaining, who are difficult to satisfy. So as far as if you're talking about premium intraocular lenses, it's extremely important to hit the target right. There have been speakers have elucidated how you can achieve that. But just in case you are unable to do it, there are several different options. Limbal relaxing incision was something I used to do for quite some time. But almost 10 years back, I gave it up simply because I thought these are inaccurate. The results do subside with time. But now with the availability of digital overlays, I once again have started doing this. It is not refractive accuracy, but what you are able to do is to debulk the amount of anterior corneal astigmatism that these patients have, and especially when you are combining this with multifocal intraocular lenses, it does help. And in case the patient presents with a problem with a residual refractive error, we often offer a LASIK or a transepithelial PRK free of cost, and this is something which is explained to the patient even prior to the first surgery. You can see those intraocular lenses shining over there. Once you have addressed the residual refractive error, it's not just the need for glasses that goes away, but we also find that the problems at dysphotopsia also subsides quite significantly. So it's usually 3 months subsequent to the initial surgery. Once the refractive error has stabilized, wound is quite stable, we go ahead and do this procedure. And just in case we are faced with a large residual error, especially if it's a hyperopic error, which is not amenable to treatment on the cornea, then it's a piggyback lens which comes into our rescue. And it's a large 14 millimeter overall diameter, 6.5 millimeter optic lens, which is gently slid into the sulcus. You can see there is already a YAG capsulotomy that is there. And this lens, once you place this, you are able to achieve good refractive outcomes. And now toric versions, multifocal versions of this is also available from Indian companies, which makes it quite affordable, and they also seem to work quite well. And in case you have had a large refractive surprise and you feel that it's basically an error in the power of the intraocular lens that has been calculated, that can happen sometimes when you're doing these surgeries in post-refractive surgery scenario. I just wanted to cut short the video. Then IOL exchange is what we do, where we cut the lens by a quarter and then explant the lens and implant the lens of the right power. And if it's a hydrophobic acrylic, the faster you do it, the better. And in case you have a toric intraocular lens that's been implanted and there is a suboptimal outcome, then all you need to do is to go in with the irrigation cannula and gently nudge the lens into the right place. If the residual refractive error, the spherical equivalent is almost 0, that is if you have a -1 with +2 diopters of astigmatism, this is the situation where repositioning of these toric intraocular lenses is going to help. There's no viscoelastic that's used. It's a 2-minute procedure, and you are very often able to optimize the kind of results that these patients have. Needless to say, if you have an opaque capsule, you need to open that up. But more importantly, when you have a multifocal intraocular lens, this is bilateral implantation, 2 eyes of the same patient, you can see the diaphanous thickening that is happening there. And the quality of vision will significantly deteriorate even with this. Having waited for about 3 to 4 months, if the patient has complaints and you think dysphotopsia is not the problem, lens exchange may not be necessary, then I would go ahead and yak this, create about a 3 millimeter opening right in the center. Decentered lenses is something that's not understood very often, but is extremely important. Again, bilateral implantation. You can see here the lens is extremely well centered by the diffractive rings, and here is decentered. It may be because there is not a good capsular axis overlap, or it can be also because of a large angle alpha. I think subsequently this will be dealt with, and that's the reason anywhere when the angle alpha is more than 0.7, I desist from implanting these multifocal intraocular lenses. You can, in case it's a suboptimal implantation of the intraocular lens, you can do a surgical recentration. Laser hydroplasty has been talked about. Does work. I've just done in a couple of patients. Too much pigment dispersal, too much pain for the patient. So this is something that I would not recommend, but it's obviously prevention is the best cure. This is again a problem that we sometimes face. Everything has gone perfectly. You can see a toric intraocular lens done by one of my colleagues in my own center, excellent surgeon, a lawyer by profession, this patient, and had very difficult negative dysphotopsia. And in these cases, bringing the optic out of the capsular bag is one of the options that's offered. But in this case, because the toric intraocular lens and the refractive error was absolutely emmetropia, I did not want to disturb the lens. So in these cases, again, putting in a sulcus lens, you can see this sulcoflex lens that's going in, is a good idea. Because it has a rounded optics, it has a large 6.5 millimeter optic, it seems to work quite well. Again, I just fast forward it a little, and that's the intraocular lens being, it is a zero power lens, purely implanted for dealing with the negative dysphotopsia. And you find that I have done it in 3 cases so far. And all these patients on post-operative day 1, they report immediate recovery. And of course, this comes at an expense, but it is something that's worth doing in case the patient is significantly troubled by this. This is what you see in the slit lamp and in the anterior segment OCT. You can see the double implant that is over there. And then, of course, dry eye. I'm going to quickly pass over this because this is something all of us know. I think the most important thing I want to recommend is when you are talking about dryness, it's most often the dryness that you have induced because of your medication. So I think post-operative medication, I strongly believe less is more. And today, it's most often lubricants that's the most important aspect of my medication. Just 2 weeks of steroids, then subsequently just twice a day non-steroidal anti-inflammatory drugs, and I find that the incidence of these problems is less. And of course, if you have a patient with a suboptimal ocular surface, I would deal with this preoperatively before going ahead with the surgery. And then in case you have doing an OCT has become a norm, not just for premium intraocular lenses, but all cases who present for cataract surgery in our center. The incidence of epiretinal membrane is almost 7% in patients above 60 years of age. And these are the common problems that an anterior segment surgeon could easily miss. And obviously, if the patient has these diseases, then you have to avoid a multifocal or even a toric intraocular lens. But sometimes if you notice them post-operatively, they have to be dealt with in an appropriate manner. The patients sometimes complain of a dysphotopsia, but they are completely happy with vision all distances. I have this simple -2 diopter glasses with me. I tell the patients that if you are very much disturbed, I'll take your lenses out and put a monofocal lens. But this is what you will lose. Put on these glasses, and this will be your reading. This gentleman has been reading his newspapers in the morning quite comfortably, but complaining of a little glare and halos. But then once he realizes the price he has to pay and what exactly this multifocal is benefiting him, he immediately says that I would rather live with the glare and halos. So experience is what counts, and it's extremely important that you explain to your patients as to what is the small price they are paying for what they are experiencing. Very quickly, I'd like you to take through some screenshots of our practical patients. This case 1, LRCS with Symphony multifocal intraocular lens was done. And what I found was what the patient needed was a +1 diopter for a reading. He was extremely happy with distance and intermediate. So what exactly we did was 2 weeks later, we went ahead and implanted a Technis plus 4 diopter lens. And because of the bilateral implantation, this is a mix and match scenario, the patient was extremely happy with the outcome. Look at this case again, a Symphony intraocular lens that has been implanted. But here the patient needed a plus 0.5 diopters for reading. Again, complaining, but quite happy with his distance and near. So what we do here is to just pump up the plus power that I'm implanting in the second eye. Can I take a couple of more minutes to show some? Okay. So this is basically the concept of mini monovision, where if the patient is requiring 21 diopters, we are implanting 21.5 or 22 diopters. And because of this, bilaterally implanted, these patients seem to be quite comfortable as far as all distances concerned. And this is something that we are doing all the time. Look at another scenario. You have a significant astigmatism in this patient, and what we implanted at TORIC Symphony. Symphony is something I was using quite often, and what we found that was the patient was again quite happy, but needed a plus 1 diopter as far as near vision was concerned. So the second eye, where basically he did a T6, and what we implanted now is a Panoptix T6 in this second eye. And because he achieved emetropia for all distances with the eye which received a trifocal lens, the patient bilaterally implanted was quite happy. I find that now with the availability of trifocals, the conversation about mix and match, about mini monovision has gone away, and most often you are able to satisfy your patients for all distances. And then again you have a scenario like this. This is to emphasize the importance of dealing with toricity. You have a astigmatism against the rule in this patient, and what we implanted in this patient was a plain panoptics. The patient was quite happy as far as the near was concerned, but you see that there is a significant amount of astigmatism that's left over, and the uncorrected visual acuity was 618. Patient was complaining quite significantly. So what we went ahead, the second eye, the left eye, the right eye, had almost a similar degree of astigmatism, and in this case we went ahead and implanted a toric trifocal lens, and subsequently what this patient enjoyed was an absolute emetropia for all distances in the eye receiving toric trifocal, and we did a laser touch-up for the first eye. So suffice it to say that nowadays we have made it a habit to subject all these patients into a toric calculator, and in case they need anything beyond a T3, then always suggest a toric multifocal intraocular lens rather than a simple trifocals or a multifocal intraocular lens. You have also got to understand that against the rule astigmatism and with the rule astigmatism are completely two different animals. You can see that this patient with a against the rule astigmatism of this magnitude requires a T4 lens trifocal, but almost a similar dimension of toricity. What you find is because it's with the rule, the patient does not require a toric intraocular lens. So that's the importance of feeding in all your data into this. Just in case you are not doing torics, but in spite of it, if in case you are thinking about just putting in some limbal relaxing incisions or arcuate incisions with a laser machine, you can see with just a 0.51 diopter of cylinder, you require a 22-degree arc. And this is something that's very easily done. You can see this almost at the first step. What I do is to go open up these arcuates. You can see a trifocal shining over there, and this arcuate definitely helps to debulk the amount of astigmatism that these patients have to deal with. On the other hand, you can see a situation like this, where it is essentially with the rule astigmatism, where there are no arcs that are indicated. This is a readout from the Varion, and it is important that you use all this. Neural adaptation is something which is extremely important. It's both the problem as well as the solution. If the physician and the patient exercises enough caution, then most often it helps to comes to our rescue. And the last slide of mine, I think I've been using it. The image might have changed, but the message has not changed, because in my 30 years of practice of ophthalmology, from my ICCE days to today, what I've understood most importantly is not the kind of lenses that you use, not the kind of machines that you use, that the empathy you have for your patients. When a patient comes to you with a complaint, it's more often an observation. If you do not counter that, you do not get into an argument with him, but tell him or her that I've understood your problem, I'm able to fix it, then most often they go back satisfied. Patients are not bothered about how much you know, but they are bothered about how much you care. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy, for very exhaustive examples and making us understand how to make the patients happy. Thank you, sir.